Okay, so welcome everyone. We are on top of the hour and for our meeting today. This is the I-CBT Friday discussion group. We're very excited for today's meeting and to have you here. Just a brief introduction to the group. We are a group of clinicians in all different stages of learning of I-CBT. And this is a space for all of us to consult cases, learn from each other, hear really amazing presentations and refine our skills in delivering care and supported our clients in the journey for OCD using I-CBT. And we want to thank you all for being here. I am Silvana Levine. I have a private practice in New Jersey, in Short Hills, New Jersey, the Good Life Center for Mental Health. And me and Dr. Springer provide evidence-based treatment for OCD and anxiety disorders. I'm also one of the co-facilitators for this discussion, along with Mary Hashborough and Margaret McCall. And today we have a really an amazing presentation in the agenda. Dr. Susan Wagner and Stephanie Woodrow will present on applying I-CBT to visual tourettic OCD. And this presentation is the first study to investigate a treatment for visual tourettic OCD. And we will discuss, or Dr. Wagner and Stephanie Woodrow will discuss the manifestations of visual tourettic OCD, and will provide a brief overview of the study design they are conducted and the results that they have obtained to this date. The presenters will also share their use of I-CBT as the treatment modality for this case series. I would like to mention that we will welcome all attendees and participating in today's discussion after the completion of the presentation. We would like to hear your comments and questions, and we will ask that you please post your questions on the chat box throughout the presentation. We will read them towards the end, and you will also have a chance to ask your questions directly to the presenters and other clinicians. We also want to remind everyone that this meeting is recorded, and we want you to be mindful of questions and disclosures brought up during the discussion portion, as we want to protect the confidentiality of potential clients who could be viewing this recording, which will be posted in the I-CBT website. I would like to take a few minutes to introduce our distinguished presenters today. Stephanie Woodrow is a licensed clinical professional counselor and holds a National Certified Counselor certification. She's the owner and clinical director of the National Anxiety and OCD Treatment Center in Washington, D.C. She specializes in the treatment of young adults, college students, and professionals with anxiety disorders, obsessive-compulsive disorder, and related disorders from a cognitive behavioral perspective. Stephanie serves various roles with the Anxiety and Depression Association of America, including being the chair of the OCD Special Interest Groups and lead of the State of the Art Clinician Sessions at the 2023 conference. She has presented at conferences and on panels for ADAA and the International OCD Foundation. And Dr. Susan Wagner is in private practice in Katona, New York. She specializes in the treatment of anxiety disorders, OCD, and obsessive-compulsive related disorders. She treats clients ages 12 and older. Dr. Wagner also consults with clinicians who want to learn more about OCD and I-CBT. And if you would like to reach out to her for consultation, you can email her, and I will be posting her email on the chat. So without further ado, I would like to give the floor to Stephanie. She will be starting the presentation today.
Great. Thanks, Sylvie. Thanks for having us. We're very excited about this topic. As Sylvie mentioned, to this point, there is no research that exists on visual tourettic OCD, VTO. So this has been an exciting adventure for Susan and myself. So because there isn't any research, the definition of what VTO is kind of evolving, and so we really have to kind of go off of anecdotal information at this point. So what we're defining VTO as is when a person is worried about staring at another person's breasts and or genitals. It's often accompanied by a feeling in their eyes that they're engaging in the behavior. And in reality, they might or might not be staring, but they're going to worry about it regardless. So some people actually are doing the staring. VTO is also been referred to as staring OCD, peripheral vision or visual OCD, and ocular tourettic OCD. But this is the current name that it's going by. So for the case series, our inclusionary data has been primary diagnosis of OCD, having VTO symptoms for at least a year, Y-box of 18 or above, and everyone has to be 18 to 65. Exclusionary criteria is psychosis, autism, personality disorders, and moderate to severe intellectual disability, no suicidal behavior or intent, self-injurious behaviors or substance abuse, and if they're on medication that could affect their OCD, they need to be stable on it for at least 3 months, and they can't have had prior I-CBT treatment. So the protocol that we're looking at is over a total of 36 weeks and includes 21 virtual meetings. So the initial session was with me, where I've done psychological and social history and diagnostic evaluation. And then my associate does pre-treatment assessments. We did 6 assessments: the Y-box, BDI, LSAS, ICQ, DRPT, and FSQ. And then from there, participants had 8 I-CBT sessions. Then again, all of the assessments were repeated by my associate. Last 8 I-CBT sessions, so for a total of 16 I-CBT sessions over the course of a maximum of 20 weeks. Another round of assessments, and then waiting 16 weeks, and again, final round of assessments. So the little people that you see on the side is where our participants currently are in the process. So, so that's where we're at in terms of our people. So we have some very, very preliminary data at this point. So all of this is what we are looking at after only 8 sessions. And I will note that if you notice the gray line, participant number 5, that is definitely not going along with the trend. So reduction in BDI scores, average reduction of 15%, Y-box scores, average reduction of 20%. Again, this is after only 8 sessions. The LSAS, which is social anxiety, average reduction of 2%. We removed participant number 5. You can still see the trend going down. The FSQ, an average reduction of 29%. And lastly, ICQ, average reduction of 12%, and DRPT, average reduction of 9%. So what the heck is going on with participant number 5? Right. So this is a quote that I love from a researcher at Harvard, Sean Aker. It's clearly a measurement error, and we know it's a measurement error because it's screwing up my data. So that's the reality of it. One thing I really want to highlight is the high correlation between people with VTO and high levels of social anxiety. We're seeing that as really common, happening very frequently. And it's because there is such, we're postulating that it is because there is such a social component to it. So, and now I'm going to turn it over to Susan.
Okay, so we can see in module 1 that there's a question here: what is staring? And it can be looked at as fixed, looking for, I can't quite see this, by looking for I can't read it.
Uninterrupted, prolonged.
Uninterrupted, prolonged amount of time, or intentional, a desire to engage the behavior. Okay. And one of the things that I want to mention here, and there's a lot of inferential confusion about what is staring for this population that we've seen so far. They are very confused between what is staring, and we'll look at this in the next slide, what is staring and what is simply looking. And in working with them on that confusion and resolving the doubt, they've been helped tremendously. All of them have had that confusion, and it's been enormously helpful. So yeah, I think you have to move the slide for me. I don't think I can do it. So we'll see over here. Does my cursor show?
No, it does not.
Okay, so if we look at these, the inferential confusion with looking and staring, as I just mentioned, that is a huge one, and they're doing so well with resolving that. And also with, am I looking at somebody's breasts, or am I just looking at their torso? And that's also really good to help them consider, because the assumption is always, oh, I'm staring at breasts. And so helping them look at the evidence, looking at what the evidence is, what their senses are telling them, has been enormously helpful. With noticing and judging, there's a lot of concern with with what are they thinking about what other people are doing. So is it possible that there's always the assumption there, or it seems that so far most of the subjects are assuming they're being judged, and even to the point where they're assuming that they're being judged, and their evidence might be that somebody had an expression on their face, and so that's evidence that they're judging them. And instead of considering that maybe they could just notice the other person. So a lot of that's outward, and then of course there is the inward. Could I just be noticing what's going on, and toward self, could I just be noticing myself, or do I have to keep judging myself? A lot of that's a tremendous amount of self-judgment. So all of these kind of areas that are Stephanie beautifully demonstrated are areas of confusion, and people are doing a good job resolving the confusion. Not each and every one, but many of them. So yeah, there's common doubts if I'm looking, maybe I enjoyed staring at her breasts. There's also the concern with, maybe I was caught staring. And maybe I can't tell that I'm staring, and maybe I can't control my eyes. Maybe I'm always staring. These are common doubts for people with VTO. And it's torturous for them. These people are really tortured. The common feared consequences include that they might be caught and judged as a pervert. This is very, very common. The social and emotional isolation. Others are going to gossip about me and reject me. Not want to have anything to do with me. Very, very common feared consequence. And other kinds of social consequences, that I could lose my job, lose my reputation, and this and the feared consequences also, like judgment. If I told anyone, they'd end up losing. They'd end our relationship. Sorry. Has, for many people, resulted in not telling anyone, and that contributes to the isolation. So there's so much fear about the consequences that that it is a self-fulfilling prophecy, that people end up emotionally and socially isolated, and that I don't really know how to move this panel, but yeah, I can't. Uncontrollable, that I don't have the
ability to control my actions or behaviors.
Yeah, and that comes up a lot. I can't control my eyes, I can't control my actions, I can't control my behavior, and it's all out of my control. So I'm going to end up just a hermit. Common compulsions include testing it out, intentionally looking to see if they were in fact staring. Avoidance, these are all very common. Avoidance of social situations or situations that provoke staring, which are obviously social ones. And looking away. Looking away can involve forcing gaze away from others' genitals, breasts, or fixating on a specific place on the wall, or fixating on someone's pointer on their face, might be on their forehead, or squinting. And then distraction, gesturing with hands, so others will notice their eyes. And then also gesturing with the hands can help distract the client too from looking. And then reassurance. Stephanie, your
Sure.
subjects
Sure. Sure. Reassurance.
Yeah,
sure. Reassurance seeking, asking others if they noticed they were staring, or asking others to watch them to observe if they were staring, and then give them reassurance about whether or not they are in fact staring.
Have your clients asked for reassurance? Because mine haven't.
Mine will have other people sometimes with them, and like in structured setting, going, let me know if I'm actually doing this.
Mhm.
And give me feedback if I'm doing it.
Yeah. Okay. So, so typical or examples of obsessional sequencing. Just an example. So a trigger might be stay still. Spending time with a platonic friend who's a lesbian. And the doubt might be, maybe I stared at her breasts. And the consequences could be, she's going to think I'm sexualizing her and then I'm a pervert. Those feared consequences are so common. And the discomfort could be that I'd be really devastated if this ruins a relationship. Very common discomfort, and I can't read the compulsion.
Sit somewhere I won't notice her, play with her cat to take away focus, hold something in front of me. And there's a couple of other examples. We're going to make the slides available so people can look at those, but basically we want to keep on moving.
Okay, so what I'm just going to say at the outset, and Stephanie's got these really cute little stars highlighting what deserves to be highlighted, is that the majority, when it comes to the logic behind visual Tourettic OCD, the majority of subjects, for them, the reason behind their doubt that really shouts out is personal experience. You just, hear it again and again and again. And this seems to be so crucial for so many of these subjects. So I'll just review the others with abstract facts. You do hear references to things like everyone has genitals. Some people do stare at Stephanie, you're gonna have to read.
Some people do stare at breasts and genitals, and things don't always go as planned. Do you want me to continue? Yep, sure, not a problem. So, social norms and rules, we're not supposed to make other people feel uncomfortable, and everybody deserves to be respected. A lot of people are worrying about what's going to actually happen, and I don't want to be disrespecting other people. Hearsay, I've heard that VTO is rarely recognized as a disorder. Most OCD therapists, are not exactly even sure what this is. So obviously the main world is not going to understand it. And I've heard others with VTO accused of being perverts, stalkers, and weirdos. And that personal experience really being very powerful, from people being confronted about staring, from people being labeled, from having people be physically aggressive with them because of these behaviors. So again, that personal experience gets really loud. And then of course it's possible. Anything is possible with OCD.
Oh, the obsessional story. Just a comment before I read this obsessional story. Only one of the subjects I've seen is actually inferentially confused about whether they're intentionally looking. For example, saying, I'm looking, so it must be intentional. And the other piece I'd like to mention, which is relevant in Module 3 and Module 4, that all the subjects report a history of trauma, either directly or indirectly related to VTO. So, so in this example, I'll read. I feel my eyes staring at women's breasts. I know that other people stare at and ogle people, so it's possible I'm doing it too. It's rude and disrespectful to do this to anyone, but especially to my friends in already marginalized and sexualized communities. When people notice they're being stared at, they talk about how uncomfortable it makes them feel. So I must be making them feel this way as well. I know others have noticed me doing this because one time, years ago, my friends confronted me or called me out on it. I also had people ask me if something was wrong with my eyes when I intentionally tried to avoid looking at women's breasts. Eventually, the women around me won't want to be friends with me anymore, and I will have hurt them and ruined all my relationships.
We have two other examples we're not going to go over now, but we do have two others. Again, you'll have access to the slides so you can see other examples of obsessional stories.
So an example of a counter story to the story you just heard. I feel a tingle in my eyes and I notice the chest of the woman standing in front of me. It's normal to look at a person in front of me and notice different parts of them and their body. I might be interested in what they're wearing or trying to read their body language. I know I would never intentionally stare at anyone. That's not me. Or especially objectify or sexualize them.
And then counter stories for the other examples.
Okay. So, so the vulnerable self-feed. And just I'll mention first that subjects report painful social or emotional isolation, and driving this are toxic shame, secrecy from everyone in their lives, that VTO with an occasional exception of sharing with a spouse, the feared possible self as a person, bad person, a pariah. So I'll just go with the doubt and the what kind of person does this make me, and go through them. So maybe I enjoyed staring at her breasts. I could be someone who could objectify others. Maybe I was caught staring. I'm someone who could intentionally disrespect my friends. I'm someone who could constantly be offending others. Oh, I'm blocked. I can't see the doubts.
Maybe I'm always staring.
Okay, that's on the
And
bottom.
the bottom is maybe I'm always staring, and the top is maybe I can't control my eyes.
Okay, so maybe I'm always staring. I'm someone who could constantly be offending others. And I take it 70.
That's okay. So again, all of these leading back to the idea of I might be someone who's immoral, and that's the most common theme that we've seen coming up as a VST with the patients. We also have a second one that we did. I could be somebody who makes other people feel uncomfortable. And again, you can always go back, take a look at those.
Great. So in this one, before we go into it, just want to mention that with module 5, subjects indicate it's conceptually great, and putting it into practice is hard. They'll also say, you know, it makes a lot of sense, but it's hard to believe. So with OCD being 100% imaginary, where's the direct evidence for my obsessional story? Nowhere, there's none. So, I have nothing to support that I'm intentionally staring versus looking or seeing. Other people being offended by staring doesn't mean that's what I'm doing right now. These points really do hit home for folks with VTO. Just because one person pointed out the behavior one time in the past doesn't mean it's a pattern or it's happening right now. My past experience is not evidence in this moment. This one is so crucial, so crucial. And just because I feel my eyes are staring, doesn't mean they actually are. And, you know, a possibility, you know, isn't evidence. Of course, we know that. So, all right, and, you know, being on that bridge, maybe I saw it because I was staring. That maybe taking you into imagination, people are grasp this image and grasp this concept, and putting it into action is really hard, which I think is true for many with using I-CBT. So there's no direct evidence in the present to justify my main doubt. I know this doesn't support my doubt, but I recently glanced at another woman's chest and she said, I think I must be cold. And then she laughed. I guess her reaction is opposite to my doubt. Sylvia looks puzzled. Okay, module 6. So again, the overall response is, this makes so much sense, but applying the principle is hard. And if you'll bear with me, I would like to contradict what I just said, and with the subject's permission, read his responses briefly to module 6. Okay? So I'm creating a fear that is not based on the here and now. I created a danger that exists only in my thoughts, inner self, insecurities. I'm becoming aware that I might be leaning into magical thinking, illusion of threat or illusion of danger. My imaginations are winning me over reality. I might be falling slave to my own illusions or doubts. I am becoming much more aware of the tricks, illusions, and falsity OCD casts upon my thoughts, my inner self. I'm beginning to be able to sort out and differentiate these opposites. Before, I was incapable or unable to do so. I was in a mental behavioral prison. It's akin to having a prison door opened, and freedom seems possible. I'm aware I must continue to learn and unlearn things. Hope is dawning on my recovery. I feel alive, better, hopeful, happy. I'm aware it may take some more time, but I'm finally being able to see how OCD tricks me. And he said, do you see how your OCD can be resolved? He says, yes. How confident? 99.9%. And then he goes on to say more, but I think he says that embracing the new powerful tools that I-CBT has equipped me with has given him so much gratitude and hopefulness. And after suffering since 1995, he is so grateful. So he's applying the principle, but it's hard. It's so hard. So yes, in my own case, there's nothing in the here and now unless I hyper focus on my sense rather than normal sensing. Hyper focusing on one's senses is a core issue with VTO. Selectivity of doubt. I'm not worried about staring at other body parts, just breasts and genitals. Why act different? By avoiding looking at breasts and our genitals. Probably looking weird.
I'm actually looking weird.
I'm actually looking weird. Thank you. So applying the principle, there's nothing in the here and now to support the relevancy of my obsessional doubt. Realizing irrelevance. My evidence lies in inaccurate and out of context logic, as well as oversensing. Okay. And I know that possibility doesn't mean probability. I can apply that to my VTO doubts. It's hard to keep the past in the past.
It's harder to.
It's harder to keep the past in the past and not assume it will happen in the present. Even though I have no evidence. The past feels like it was yesterday. This is good. I feel like a child when I remember how different my life is
Currently.
Specific ways in which it's different. I'm more present. And this is so good. And then the past goes back to where it belongs. Got it. I have to keep working at this so the VTO doubt can become truly irrelevant. This is so helpful. So that is my portion. Stephanie, take it over.
So when we're talking about the OCD bubble, again, we're getting trapped in that out of context information and those personal experiences about what other people are doing or what's happened to us. And that's what keeps us in the bubble. And so to pull us out of the bubble, we need to be focusing on reality sensing, which is a really challenging module for and skill for this population. We'll get to that in a minute. So with normal perception, people are, going, okay, I'm noticing this, I'm seeing this, I'm noticing a necklace that my best friend also has. I'm, other people aren't hyper-focusing. I notice lots of things about people, but with people with VTO, it's really a hyper-fixation and going, and my eyes are absolutely fixated. I'm not noticing anything else about the other person. I'm just noticing breasts. I'm just noticing genitals. That thinking of, I can't stop staring, so therefore I must enjoy it. And other people are catching me or other people are noticing me. And so in practicing reality sensing, one of the things that's really difficult is making sure that they're not over-sensing, where they're hyper-focusing on not doing something or monitoring themselves doing it. And because this is, and so doing that idea of just looking at the whole person, and even just doing not what we traditionally refer to as a body scan, but recognizing the entire person and going over the entire person and going, yeah, I'm actually seeing multiple things about the same person. And this is a module that we're usually spending a little bit more time on because this is a more difficult skill with VTO. And a different story. I know I'm not staring at women's breasts because I find that behavior disrespectful, and I'm not that type of person. I'm noticing lots of parts of women's bodies, including their hair, jewelry, and shoes. It's normal to notice lots of things about people when I'm looking at them, and I'm looking because it shows others that I'm engaged in a conversation to look at the person I'm speaking with. It's important to me that the people I interact with know that I care about the exchange, and my actions of looking help them convey that message. After we do the alternate story, I usually have them go back and read their obsessional story so that they see the real difference between them. And one of the things that they keep coming back with is, I feel so silly, or that feels so ridiculous. Sometimes they say I feel stupid. And of course, we have to do normalization with that. But being able to come back to the real self is a huge component for a lot of people with this. Of all of the tricks and sheets of the OCD con artist, I think there's 8 that kind of jump out a little bit more. Mismatching out of context facts, living the fear. Living the fear is a big one. I was worried, I was staring, and now I feel my eyes staring, glued to that person's genitals. Does that mean I really am staring? And that goes along with the compulsion of, I'm not sure if I'm looking, so I'm going to check if I'm looking, and now I'm actually looking. But wait, am I actually looking, or am I just feeling it looking? So that's a cycle that people actually get into very frequently. Distrusting of the senses. Again, that feeling in the eyes, a lot of people, that's where the tourettic component comes in, where they're feeling something in their eyes that needs to be addressed. And the testing it out also goes to the compulsion component. I would say that one is the other really big trick that we're seeing. I'm going to give myself permission to look at the person's breasts and genitals and then observe how they're reacting to me to check if they noticed. So, and especially if we're encouraging them, which we're not doing in this case series, but if we're encouraging people to, take a sneak peek and just look, this is actually reinforcing this trick. And the real self, and such a wonderful module and so important with this population. Based on my attributes, who am I? I'm a thoughtful person who cares about others' feelings. And what are my real feelings and desires? I want to talk to this person. I want to connect with them in a meaningful way. This is actually the opposite of my OCD. My friends say that I'm extremely caring and empathetic, and this is not in alignment whatsoever with what my OCD says. And the relapse prevention. So we really want to focus on that inferential confusion between the difference between staring and noticing, staring and seeing. That's really key. And with reality sensing, going to that point of the difference between sensing and hyper-focusing or hypersensing. Those high-risk situations, those social situations are going to be tough, especially close-up situations, women with large breasts, ones where people may be noticed. Normalizing slip-ups, recognizing that we can catch the OCD and move on past the doubt, and resolution of OCD. I'm not giving the obsessional doubt any credibility, and therefore I can focus on the real present. And I just want to give thank you to my associate, Mariam Katami, who has done all of the assessments for the case series, and we're excited by the numbers, other than participant number 5, who none of them know what their numbers are, so it doesn't matter. But we're excited to see what the rest of the numbers are. Happy to take any questions.
Yes, Susan and Stephanie, this was an unbelievable presentation. Thank you so much for sharing your materials and your really masterful application of I-CBT in this very unstudied and deeply looked and misunderstood population. There were a couple of questions and comments that came out in the chat. The first one is that everybody is raving about your presentation materials and they want to have access to to your PowerPoint presentation. Would this be available for somehow, or would you email it to some of us?
Yes, as Ronwin has made me cooler, this is a Canva, and I'm happy to provide provide the link or provide a PDF of it. Not a problem at all.
It was very interesting to see how you conceptualize each module, how you kind of led the client to those conclusions in each module. That was actually a very useful material. And I can see that could be applicable to different forms, not only Tourettic, right? Like that it could be trans OCD theme kind of thing. I think it was very clear. There was also an exchange that took place. There was a question presented by Mandy Taylor, in which she was wondering what happens when the person in the middle of wondering if they stare or not, if they would actually be doing something in relation to their breast or the genitals. And I think, Stephanie, you answered that there is a direct evidence in that moment that the person is covering the genitals or their breast, but that doesn't necessarily mean that they cause it by the staring. And Dr. Ardima supported that, indicating the importance of the direct evidence has to be present in order to support the doubt, and not to be an obsessional doubt, but a corroboration of a reality problem. I wonder if there's other questions in relation to that. How do you guide clients how to manage if the persons they're interacting with have any kind of behavior in relation to sexual organs? If there's any, how do you address that in treatment, other than like, is there direct evidence in it here now, or is that sufficient?
I think the modules that I'm spending the most time on are module 1 and focusing on the inferential confusion, more the concept of inferential confusion, much more than the sequencing itself. Not that I'm not doing the sequencing, but the concept of inferential confusion is so key. And so going back to that idea, and then module 5 and module 8, I would say those are where I'm spending the most time. And again, going to that direct evidence where, yeah, people adjust themselves. Yeah, people get uncomfortable. People touch their faces. People touch their bodies. But we don't have any direct evidence of the reasons why they're doing that unless they're vocalizing it and you're actually hearing them say it. So just because you're seeing it, what you're seeing is an adjustment. You're seeing them touch something that the only time that you are the cause of that is if we have additional direct evidence or if you go over the bridge. We don't want you going over the bridge.
Yeah, context, right? Like you brought the context of the human experience in relation to their bodies, right? What is normal behavior for every human being in general in relation to their body parts, and if that constitutes or not evidence in the here and now that their staring has produced that behavior.
Yeah.
Oh,
go ahead. I'm sorry.
no, go ahead, Margaret.
I have a question, well, a comment too. I never had a client with this form of OCD, and I always assumed, because it was called Tourettic OCD, that they actually were staring like a tick. They were actually doing it. And so this has given me a huge more information, like, oh, I can totally understand why someone would be inferentially confused here. So I just want to, am I correct in saying in this situation, then if they're staring, they're testing, and typically they're not staring, they're just looking and are misinterpreting that as staring?
If it's really Tourette, then we're dealing with a different problem. This is an OCD, and they get this term Tourettic in there, but it's still OCD, and that makes it confusing. I think it's important to pinpoint the inference of confusion here, right? First, if you allow me, I mean, Susan and Stephanie, great presentation, beautifully done. And so I-CBT is so well applied to that, right? In all of its aspects. It's a complicated, a seemingly complicated area. It's a little bit like what we see with pure obsessions and four-fault fusion, right? And that's what I want to point out. What is the inference of confusion in here, really? And the inference of confusion really revolves around that the person is so afraid of looking or staring that they start self-monitoring while they are looking, and they get stuck in that. That's really the confusion. It's sort of like the behavior starts to light up, or what exactly the thing they want to avoid, their eyes are going towards. But it's self-monitoring. It's not something they do with or it comes out of a fear of looking, not out from a place of immorality or whatever it may be. And that is the confusion that people are caught up in, right? So, and being able to explain that, saying like, no, you're looking, you're noticing these things because you make it happen out of the fear of it being more than just that. But what you're really just doing is just self-monitoring, which then brings the thing you fear into view. And we see the same thing happening with repugnant obsessions or unacceptable thoughts, those sort of things, where the person fears having these thoughts so much that it starts to pop up in their mind, right? It's a similar process. Confusing what and knowing where it comes from, that it doesn't come from a bad place, but it simply comes out of fear. That's the confusion you're trying to resolve here. And I thought it was very well explained. Yeah, both of you. So great. And you should make a workshop out of this, both of you.
All the results first before, and let's actually figure out if this is actually working and sustainable before we go any further with that.
You also have a whole presentation, I remember, of on Canva, right? On
this is so this is Canva. This is Bronwyn inspired Canva.
Right, right. But you also have a whole presentation on more like how you apply it to Tourette OCD, correct? This is the application of it, but you have another presentation somewhere.
Yeah, modified version. So in the case series that we're doing, we have a modified version of this that we go through with the patients week to week. So yeah.
Fred,
that I would completely change now, but of course we're in the middle of the case series, so I'm not changing it because it has to remain constant, but I would change a million things about it now.
Well, along those lines, I wanted to ask you and maybe talk about it at some further point, but you know, if when we conclude the study and the results look, or the case series, if the results look good, you know, is it possible to design a treatment study that allows more flexibility in the treatment itself, like with the pace of the treatment, the teaching of modules, flexibility with the sequencing of the modules, going back and reviewing an earlier that kind of thing?
Sure. I mean, what you're doing is you're applying I-CBT to a particular, let's call it a subtype or a particular symptom dimension of OCD, right?
Yeah.
And as long as it's OCD, then the I-CBT model and the modules can be applied to it, which is exactly what you're doing, which is great, with your own clinical insight and in an area where we actually a form of OCD that's very little talked about, you know? And to take it from a case series to a trial, yes, that would be quite a specific form of trial because you're focusing on one symptom dimension of OCD. But yeah, for sure, that's of interest. Yeah.
I will say there's a Facebook group specifically for VTO, for for people with VTO and for clinicians who treat VTO. And when we said that we were doing this, there was a lot of excitement just because there hasn't been any research done. There haven't been any attempts at it. So the fact that there are kind of hypotheses about that are more coping skills than anything else. So right now, patients are really just using coping skills as opposed to having treatment. So the idea that there could be an applicable treatment is very exciting for a lot of them.
And in our trials, actually, we have some people as well with VTO, who have this problem, but study specifically focused on this subtype. Yeah, for sure, it's interesting. But it starts with a case series, and I'm glad you guys are doing it.
I wonder if the clients that you have seen in your trial, in addition to VTOs, are other forms of presentations of OCD, or is just purely VTO? Like, do they struggle with other obsessions, not necessarily specifically with VTO?
Yes.
I mean, there's often
Mine
comorbidity.
did.
Yeah.
Yeah, I mean, but it's some of them have just pure VTO, but more often in OCD you see different symptom dimensions. The person has checking, they have other issues at the same time, but it depends. It's just, I would expect it to be a similar distribution. Sometimes there are other obsessions as well, and sometimes there's not, so it differs.
Yeah.
I will say the concerns that I hear voiced the most, number one is they voice the VTO concerns, and then number two concern that they express is the social anxiety concerns going along with it. So they'll say, yes, I've had other themes, or yes, I have other themes going on, but this is the dominant, and that was what was necessary for the case series, that this had to be dominant in what was going on for at least 12 months of symptoms. And for most of them, it was years and years.
Yes.
Oh, wow.
So the social anxiety, the consequences, though, right? It's a secondary.
Secondary.
It is.
Yeah, usually it is. It's because I think what Sylvie was talking about was other forms of OCD that occur together with the specific VTO type of OCD. So person may also have contamination OCD in addition to VTO, and that sort of these different type of combinations. Usually, a person has more than one form of OCD at the same time, but one is predominant, But in the case of social anxiety, yeah, I think it's quite often a consequence of the doubt, because you wouldn't get anxious when you think that you're intentionally staring at somebody's breast and you feel you have no control over it, and right? I mean, it's a normal consequence in a way. The problem lies with that there's no bad intent behind it, and that they're confusing their own fear of looking with staring.
I think one of the things that's actually terrific about this is, although we don't have research on I-CBT for social anxiety yet, anecdotally, I think a lot of us have seen benefits to it. And so the idea that these are the two main concerns that people are addressing, and we are seeing the LSAS scores going down, I think that that's a reflection as well of the usefulness for I-CBT for social anxiety, even though that's not directly what we're looking at here.
And I'm cognizant of the time is 2:00 and we have to be ending the meeting. I was wondering if other clinicians struggle to maybe making a clear differentiation. Maybe we can continue the conversation, maybe on the Facebook group, between sensory motor OCD, Tourettic OCD, Tourette's, because there's kind of, I wonder if they're like, what are the specific differences for diagnostic purposes as well. But as I said, when we are on the top of the hour, and I want to thank you both for an amazing presentation. We really are very excited for your research and the support for this community. And thank you everyone for attending and being a part of this group and cooperating with everyone.
Well, thanks for having us.